I'm Gabby Karaka, an A semester nursing student. Today's date is February 9th, and I will be explaining a chest tube. The first thing I'll do is introduce myself to the patient, get name and date of birth for my patient, provide for privacy, and perform hand hygiene. Next thing I'll do is explain the procedure. So we have to place this chest tube because of a trauma that led to bleeding in the pleural space. So we will do so by a chest tube. This was found on imaging. So the provider will place this chest tube and we will pre-medicate the patient with some pain meds for any discomfort because they will be awake. And then this tube is one of our tubes that will be for the chest tube. When he inserts it, he'll insert it in the intercostal space of the rib cage here on the side, and it'll be the top tube will go towards for air drainage, and it'll be near the apex of the lung, and then the bottom drainage will be for any of the liquids such as the blood in this case, and it'll be near the base of the lung on the side, and each of those will be sutured in place and dressed with an airtight dressing over top of them so that there's no air leaks or crepitus that can occur. We have our tube here, so that will be connected to each of the drains by a Y connector, and we'll make sure to address those so that they are sealed properly so no air leaks can occur. And then we have our actual system here. So we have our 3 chambers here. We have our collection chamber, our water seal chamber, and our suction chamber. Our collection chamber is simply the output that we get from the actual chest tube drain itself. So it'll be the amount of blood in this case, and it'll fill up here, and each shift, every 8 hours, we will mark this with a line indicating where the drainage is at, and date, time, and initial it so that we know how much output has happened in the last 8 hours. If we see that our output is more than 70 mils per hour, that is cause for concern, and we would want to notify the provider immediately. The next chamber we have here is the water seal chamber. Here is the funnel that you would put the water into, and you would make sure to fill up the water to at least this 2 centimeter mark. That is the standard amount that you should put in the water seal chamber, and for this will tell us if we have titling and air leaks. So titling is normal. We want to see that just based on their normal respiratory rate and pattern of breathing. So when we see this little ball come up here to the 2 centimeter mark when we fill it with water, we'll see that it rises and falls slightly depending on their breathing. If they're a deep breather, then it might rise and fall a little bit more dramatically than somebody that shallow breathes, but we still want to see that. It is normal. As far as air leaks, we can see those normally in the very beginning stage of placement of the chest tube, but if they get excessive bubbling here or continuous bubbling, that is a cause for concern because that does indicate an air leak is occurring. What we can do for that is we can first just check the dressing sites and the tube connecting Y connectors. We want to make sure that if there is reason for the air to get escaped into the tubing or around the dressing, we can just address that, maybe apply a new dressing to it. If we see that the connectors and the dressing are placed properly, then we want to make sure and notify the provider because that could be an air leak in their lungs. The last chamber here we have is the water seal chamber, and again we would pop this off and fill it with water. For this specific chest tube system, 20 centimeters of water is the baseline, but we want to make sure that the provider has an order for exactly how much they would like this filled. Now, the suction chamber here only works when the wall suction is turned on. So again, we would want to make sure that the provider has that noted as an order, and if we need to turn it on, we can turn it on through the wall suction. If it needs to be turned off, we just turn it off through the wall suction. We never empty or drain any of these chambers for any reason. So on to assessment. We want to assess our patients frequently. Every shift, every 8 hours, we want to assess the respiratory their respiratory system, their vital signs, their cognition level. We also want to assess if they have any pain or discomfort. And then we can also assess imaging as needed by the provider. And another thing we can assess for is that crepitus. We would see that as the air around under the skin. We do not want that to happen, so we can assess the drainage site and palpate that, and if we feel it, then we would definitely need to notify the provider because that is not normal. The next thing we'll do is also explain and do some patient teaching. We want to teach our patient that they need to use their call light as much as possible because we don't want either of these tubes to come dislodged. We don't want the chambers, the system here to fall over. So they really need to use their call light if they need to get up, repositioned, go to the bathroom, anything like that. We need to let them know to use their call light. We also need to let them know to report if they're having shortness of breath or pain at any time, and we can address those things. And then we also just want to have them cough and deep breathe regularly as they need to work on re-expanding their lungs. Once this is discontinued, we can explain that procedure to them. So usually this is only placed for about 2 to 3 days depending on the lung re-expansion and depending on imaging. So if imaging looks good and their lungs are re-expanding, the physician will order to discontinue the chest tube. So when we do that, they can do it at the bedside, and if they need meds for medications for pain, they can do that. But again, they're awake, it's done at the bedside, the provider will discontinue it. And once he does discontinue it, we want to make sure that we place this entire system into a red biohazard bag and place it in our dirty utility room. Again, not emptying any of the chambers, they're just going to stay that way, and we dispose of it like that. And that's all.